Hello everyone, greetings. So salivary glands have very interesting histology and an equally interesting pathology, a pathology that keeps on changing so much that they are almost as fluid as the saliva in them. We are constantly adding and removing things from the classification, and it's always interesting to remain updated. And the best way, of course, to do that is to see case discussions. And today we have one such event. We have a case discussion with us, and right. So I welcome you to today's lecture, Rare Salivary Gland Cancer as a Case-Based Discussion. Right. Of course, let me first begin by saying welcome. And it's nice to have you with us for one more episode. In case this is your first time here, I'm Dr. Mandana Donahue, and it gives me great pleasure to welcome you to Oral Pathology 360. Now, coming back to today's lecture, we have with us Dr. Neda Karduni from the Tehran University. She is Assistant Professor of Department of Oral and Maxillofacial Pathology from the School of Dentistry of the Tehran University. Now, she has given us very kindly the lecture as a video, so we will be playing that and then having a discussion subsequently. But just so that you can say hi, yes, hi Neda, you're live.
Hi there, Mandana. Hi, good morning to everyone. Thank you so much for your attempt and for your invitation. Thank you.
You're most welcome. Our pleasure. So with this, we'll just go on with I will add the video. We will watch the video and then we will come back for the discussion.
Case number 1 is a 52-year-old man who came with a chief complaint of left party swelling and pain for few days. On MRI imaging, a hypoechoic mass with irregular borders measuring 30 by 16 millimeters with multiple lymphadenopathies are evident. Axial MRI sections show hypoechoic again parted mass on the left side of the patient. Subsequently, a sample of 9 glass slides of FNA accompanied with a syringe containing 2 ml of bloody fluid were obtained, and under the microscope only macrophages in a bloody background were seen. Finally, the patient underwent total paroidectomy. Let's have a look at the microscopic examination. The H&E sections showed proliferation of epithelial cells mostly arranged in solid nests in this slide. With higher magnification, cribriform pattern in some areas with solid nests are also seen. As can be seen here, the tumor is composed of solid and cribriform patterns with mucinous secretions within the glandular lumens and focal areas of inflammatory cells, mainly chronic ones, infiltration within the tumors. Other areas of the tumor show multiple cystic structures with variable size and smaller ducts. The cysts and ducts display a diverse architecture with multiple patterns and a heterogeneous luminal epithelial proliferation. The pseudocribriform pattern is also evident within this section. Secondary changes, including presence of hemorrhage within the lumina of the cystic structures, are also seen within this slide. At high power magnification, tumoral cells shows bland but heterogeneous cytologic features, round to oval nuclei, which may contain finely dispersed or dark condensed chromatin, and the mitotic activity or mitotic rate is low, and generally cells lack cellular or nuclear polymorphism, prominent nucleoli, and significant mitosis and necrosis. Most neoplastic islands are surrounded by intact rim of flat and myepithelial cell, which can be seen here at the periphery of this island. For making definite diagnosis, immunohistochemical studies were done, and on this slide High molecular weight cytokeratin staining is shown. As can be seen, diffuse strong cytoplasmic and membranous staining of high molecular weight cytokeratin was seen within this tumor. P63 was positive in peripheral rimming of solid islands and cells lining cyst-like spaces as well. S100 immunostaining shows strong diffuse immunoreactivity for the tumoral cells. Most of the islands and nests are stained with this immunohistochemical marker. In this slide, I want to show you the comparison between the two myepithelial markers, S100 and P63. The S100 is positive in all the tumoral cells. However, P63 hallmarks for you the peripheral rimming of these myepithelial cells, and this pattern is unique for a kind of salivary gland tumor, which we are going to discuss it. Another immunohistochemical marker used to differentiate between the main differential diagnosis was DOG1. It was completely negative in all tumoral cells. Okay, by the next slide, I want to discuss the main differential diagnosis came across our mind while we were signing out these specimens. When we came across the definite diagnosis for the patient, list of benign and malignant tumors were in front of us. And in the list of benign category, we had cystadenoma, sclerosing polycystic adenosis, ductal adenoma with striated duct differentiation, and intercalated duct lesions. However, some features helped us to distinguish between these tumors and our patient diagnosis. The cystadenomas are uncommon lesion and neoplasms of the salivary gland. They are well circumscribed and composed of variable size cystic spaces with a lining epithelial of variable appearance. They had no cellular atypia, solid growth, necrosis, or mitosis. Some features were present, however, in our case. Sclerosing polycystic adenosis, which present as a sclerotic nodule, which was not that much okay with our diagnosis and our patient. Ductal adenoma with striated duct differentiation is grossly solid and encapsulated, and that helped us to distinguish it from our patient diagnosis. About the intercalated ductal lesion, these are small lesions composed of small ducts with a mixture of blunt duct, acini, and mucous cells surrounded by a continuous layer of myepithelial cells. Okay, let's have a look on the other differential diagnosis. Within the low-grade malignant list, we had cystadenocarcinoma and salivary duct carcinoma in situ, and some features are helpful to distinguish these tumors from ours. Within the cystadenocarcinoma, we have clearly infiltrative neoplasm. We have lack of cribriform architecture and lack of non-neoplastic myepithelial cells. What about the salivary duct carcinoma in situ? The nuclear grade, the presence of necrosis, and negativity expression of S100 could be helpful to distinguish this category as well. Among the high-grade malignant tumors, conventional salivary duct carcinoma, actinic cell carcinoma, papillary cystic pattern, and secretory carcinoma of the salivary gland were the main differentials. About the first category, both intraductal and widely invasive components are present. Immunohistochemically, it is positive for AR and DFP15, and negative for S100 protein. I think you can get the point that S100 and other features are helpful to distinguish from ours. About the second category, actinic cell carcinoma, by immunohistochemical staining, negativity for S100 could be helpful. And in our case, it was strongly diffuse positive. About the mask or secretory carcinoma of the salivary gland, it is positive for mammoglobin, S100 protein, vimentin, and cytocrotin, as well as MUC1, 4, and high molecular weight cytocrotins. It is negative totally for P63, which was the main positive marker in our case, as well as it is negative for calponin. Finally, we decided to make this diagnosis for the patient, and we designated this tumor as a low-grade adenocarcinoma with significant intraductal growth, suggestive of intraductal carcinoma low grade. And let's have a look on this entity in the upcoming slides. Low-grade salivary duct carcinoma or low-grade cribriform cystadenocarcinoma, first described by Delgado in 1996. And in the 2005 WHO publication, the name low-grade cribriform cystadenocarcinoma was made for this tumor. According to the last classification of head and neck tumors of WHO in 2017, low-grade cribriform cystadenocarcinoma were categorized as a low-grade intraductal carcinoma. So finally, the name is LGIC. Low-grade intraductal carcinoma is an extremely rare neoplasm with a wide age spectrum ranging from 26 years old to 93. Slight female predilection was seen within this neoplasm. The parotid gland is the most common site of involvement, and it followed by accessory parotid, submandibular gland, and minor salivary gland. Asymptomatic, slow-growing mass with no facial nerve paralysis is the most common clinical presentation of these patients. This rare neoplasm composed of both intracystic and intraductal growth, as I think you can remember from our previous slides in the patient. The luminal ductal phenotype shows bland microscopic features. Some lesions resemble the spectrum of breast lesion, atypical ductal hyperplasia to microcystic, micropapillary and cribriform low-grade breast carcinoma in situ. The main proposed criteria for the diagnosis of pure intraductal carcinoma of salivary gland is given in this table. However, I want to emphasize on the exclusion of an invasive component by thorough sampling. It is very, very important to exclude the presence of invasive component in this tumor. The immunohistochemical findings for this tumor is as follows. The predominant cells, the ductal phenotypes, are cytocrotin positive, AE1, AE3, which is pancytocrotin, cytocrotin 7, 8, 18, and 19. EMA is also positive. Regarding the ductal cells, they are diffuse and strong nuclear positive for, and also cytoplasmic for S100 protein. About the rimming myoepithelial cells in cystic spaces, SMA, calponin, P63, and cytocrotin 14 could be helpful. In both ductal and non-neoplastic myoepithelial cells, high molecular weight cytocrotin and proliferative index of less than 1% are helpful to distinguish this tumor. The absence of ER/PR, AR, and HER2/neu are also should be considered in this immunoprofile. In conclusion, due to rarity of these low-grade intraductal carcinoma and limited experience in dentists, oral and maxillofacial surgeons, otolaryngologist and primary care physician, we have to make a right diagnosis to minimize the treatment invasiveness, avoiding adjuvant and unnecessary therapies, and maximizing the patient quality of life. I hope you have enjoyed the case number 1, and let us go to the case number 2, which is a 59-year-old man presenting with a cystized ulcerative red-white lesion with indurated border at left maxillary vestibule for 2 months. In this slide, you can see an obvious mass at the vestibule with some extension to the labial mucosa of the upper lip. The patient underwent incisional biopsy, and as can be seen here in this section, solid nest of cells separated by thin cords of stroma can be seen under the stratified squamous epithelium of the oral mucosa. With higher magnification, maybe the nature of the cells are more evident. Let's have a look on more sections. The tumoral islands, the two main ones, are separated by the thin fibrous stroma from each other. These islands are composed of basaloid cells with large round nuclei, round to oval nuclei with little cytoplasm, which in some parts they may form cribriform pattern, and some secretion within the spaces can be seen as well. Most tumoral cells have limited microtic activity, and nuclear or cellular polymorphism is minimal as well. At the periphery, the arrangement of peripheral cells is somehow palisaded, and they have palisading pattern at the periphery of the islands. For further elucidating the nature of the tumoral cells, immunohistochemical markers were applied. For example, cytokeratin 5-6 were strongly positive, as can be seen in this section. Membranous and cytoplasmic expression of cytokeratin 7 in low and high magnification are shown here. P63, which is a marker of basal or myoepithelial cell differentiation, was positive at the periphery of the islands and tubules. Smooth muscle actin, which is a sensitive marker of myoepithelial cell differentiation, is strongly positive within the cytoplasm of the tumoral cells. Marker of proliferative activity, which is Ki67, is positive in hotspot areas of the tumor and is estimated approximately 10%. If we want to summarize what we have found so far based on immunohistochemical and histomorphological findings, and if we want to summarize the list of benign and malignant tumors based on our findings, we may come across basal cell adenoma in the benign category and 3 tumors in the list of malignant ones: solid variant of adenoid cystic carcinoma, basaloid squamous carcinoma, and basal cell adenocarcinoma. From the beginning, which is basal cell adenoma, benign tumor, we may say that this tumor lacks some criteria which was found in our neoplasm: the lack of invasion, low mitotic activity, and some proliferative activity less than 5% could be considered for this tumor. However, the infiltrative and destructive growth into adjacent structures shouldn't be found. There are some common prominent features within the list of malignant differentials, including invasive growth of the tumor, cribriform pattern presence, palisaded basaloid cells at the periphery, and hyaline extracellular matrix. These features are common within the three main malignant differentials here. The first one, which is solid variant of adenocystic carcinoma, has cells with more uniform hyperchromatic small angulated nuclei than the two main entity remaining ones. Within the basaloid squamous cell carcinoma, hyaline deposition and cribriform growth structures are present, as well as presence of squamous cell differentiation. And in addition to this, squamous cell carcinoma in situ or presence of dysplastic changes within the overlying epithelium could be helpful in diagnosis. Mitotic activity and cellular polymorphism are higher in this entity than the two main remainings. So in basaloid squamous carcinoma, we predict more mitotic activity and cellular polymorphism atypia than the two others. The next one, which is basal cell adenocarcinoma, is an entity which is mainly important to differentiate it between this one and the adenoma counterpart, I mean the basal cell adenoma. In basal cell adenocarcinoma, the cribriform nests are composed of uniform basaloid light cells in the center and dark cells at the periphery, within palisaded architecture at the peripheral areas. And it has some nuclear features, basaloid features, and some peripheral palisaded arrangements, cystic changes, and areas of squamous cell differentiation, but smaller than that one in basaloid squamous carcinoma. Since the final diagnosis in this case was based on the presence of invasive growth into adjacent tissues, and the immunohistochemical profile was not useful in distinguishing from the entity of basal cell adenocarcinoma from its mimics, namely adenoid carcinoma and basaloid squamous cell carcinoma, we finally designated the case as an infiltrative salivary gland neoplasm with histomorphologic and immunoprofile consistent with basal cell adenocarcinoma. Due to the lack of time, I will not give you a full explanation about the tumor, but I want to highlight some important points. It is more common in the superficial lobe of parotid gland, and it has a well-defined non-encapsulated limits. The four main growth patterns are tubular, trabecular, solid, and membranous types. As it was shown in this case, we had the mixture of these patterns. Even we had areas of membranous differentiation, which was the hotspots. The hotspots were located over there for the Ki67 proliferative activity. We had more expression of these marker in the membranous areas, and it could range between 25% even to 30% in that areas. The solid pattern is most commonly encountered one, and the presence of hyaline basement membrane related materials may form for you this pseudocribriform pattern. And these are the main points, and let's have a look on the treatment and prognosis of the patient. Based on literature review, the local recurrence rate for these tumors is approximately 37%, and the rate of locoregional metastasis is around 8%. And the optimal treatment includes wide surgical excision of the specimen with free margins, and there is no need for additional radiotherapy and elective neck dissection, and we have to keep in mind that these treatments are not considered as a routine ones for basal cell adenocarcinomas, while where the margins are not free, we can consider this treatment as well. The basal cell adenocarcinoma of minor salivary gland, which was in our case, have more aggressive clinical course than those in the majors due to the tumor stage at time of presentation. The last case, which is case number 3, is a 52-year-old man presenting with a pedunculated firm pink nodule at the maxillary left vestibule for 1 year. The patient underwent excisional biopsy, and within the H&E sections, we found the proliferation of tumoral cells in low magnification, which are surrounded by hyalinized stroma at the periphery and within the lobules of the tumor. The tumor presents as a solid mass divided by fibrosepta into irregularly shaped and sized nodules. The nodules composed of cells with round nuclei and different architectural pattern. The tumor cells have invasive growth, and as can be seen in this section, the striated muscle fibers are invaded by the tumoral nests in some parts. Typically, the tumors also include intermingled tubular, solid, and cribriform growth patterns, as can be seen in different sections. The main feature and the most prominent feature of the tumors is the presence of the nuclei, which are overlap one another and are pale, optically clear, and vesicular with a ground glass appearance. The peripheral layer of such solid tumor nests often display hyperchromatic nuclei with the aforementioned features in the palisaded growth pattern. The presence of papillary growth pattern in some area of the tumor is also evident. Here more papillary growth with presence of somehow mucinous cells within the proliferative tumoral cells can be seen in this section, which can occur in this entity in some cases, but not unusual finding in this tumor. The immunohistochemical profile of the tumor is as following. S100 is based on the histomorphologic findings and immunohistochemical profile of the tumor. The diagnosis of cribriform adenocarcinoma of the tongue and minor salivary gland was made for the patient. It is an unusual, or let's say rare, neoplasm of salivary gland, which accounts for less than 1% of the tumors of salivary glands. It was originally described in 1999 by Michel and typically occurring in the posterior tongue and retromolar region with concurrent metastasis in the lateral neck lymph nodes. This exceedingly rare neoplasm occurs equally in male and female, with more occurring in the African American and Africans, and it is preliminarily occurs in the tongue in posterior areas. However, there are some cases of these entities described in soft palate, retromolar, buccal mucosa, lingual tonsils, upper lip, and epiglottis. Based on a comprehensive literature review and a systematic review published in 2022, there are only 56 case reports of this entity within the literature. As a brief review on the criteria for diagnosis of this entity, we can hallmark the histologic criteria, which almost always, and this tumor covers by an intact squamous epithelium, devoid from any ulceration or dysplastic changes. The lymphovascular invasion is observed in a third of cases. However, the presence of metastasis in 50% of the patients can be seen at the time of diagnosis, and is an important point if we want to conclude. Another thing is that tumor themselves are composed predominantly of cribriform to microcribriform and solid structures in variable proportions. If we want to conclude the immunoprofile of this tumor, the S100 as well as smooth muscle actin, cytokratins AE1, AE3, 7, 8, and 18 are positive, and c-KIT or CD117 is also strongly positive in this tumor. Based on the histologic and IC findings, which was pancytokeratin S100 and cytokeratin 7 positive, SMA mild focally positive, P63 strongly diffuse positive in nuclei of tumoral cells, and Ki67 around 2% in hotspots, and the presence of TTF1 negativity, which can exclude for you the origin of the thyroid gland, I mean the papillary thyroid carcinoma, which has some similarities in the histologic findings, I mean the overlapping nuclei or orphan aneapparence of the nuclei. The final diagnosis of low-grade infiltrative salivary gland adenocarcinoma, consistent with cribriform adenocarcinoma of minor salivary gland, was done for the patient. Here, I just wanted to introduce this variable article I used at the time of diagnosis. In conclusion, I just want to say that this entity, the cribriform adenocarcinoma of tongue, base, and minor salivary gland, is a new one and relatively rare salivary gland neoplasm. But due to presence of histologic and immunohistochemical profile, it should be considered as a distinct entity and should be separated from the main differential diagnosis, which is polymorphous adenocarcinoma. And we should rule out at the time of diagnosis the presence of metastasis, especially from the thyroid origin. I mean, the papillary thyroid carcinoma should be excluded. And the other thing, which is the main point regarding this tumor, is that 50% of the cases, as I mentioned before, they came with a metastasis at the time of diagnosis, and you should guide your surgeons to evaluate the patient as a whole, and the presence of metastasis should be ruled out at early stages. Hope these cases, which are rare cases, can help you to consider more differentials when you are signing out your patient's diagnosis. Hope you enjoy them and have a good time.
Yes. Thank you, Dr. Neda. That was a very interesting and very informative collection. And so far, we don't have any questions. Let's see. Yes, as usual, please put in your questions or comments in the chat box, and we shall get them here. For now, we have a comment from Dr. Puyan, and he says it was a very well descriptive IHC stain microscopic slides, and truly they were. I have to agree, they were very nice. Yes. So, any other questions? Okay, we have something. Yes.
Okay, now I have here. I'm here. I lost my connection, I think, for a moment, but I think everything is okay now.
Great. Okay, we have a few comments and questions. I will bring the questions on. Right. We have one from Dr.
Thank you.
Puyan. It says great cases. And then how can we differentiate CAT from PLGA using IHC study?
Is it possible to answer right now or by the end of the questions?
No, you can answer it. His question is there. Please answer. Uh, Dr. Neda, your mic is off.
Okay.
Yeah.
By the aim of immunohistochemical staining, actually, I think it's
Sorry,
it's
don't
okay.
mind me. I'm looking at
We
other
may have
screens.
some delay
Okay.
in the transformation. Okay. By the aim of immunohistochemical staining, the differentiation between polymorphous low-grade adenocarcinoma, or let's say adenocarcinoma of the salivary gland, and CAT is impossible, actually. We have to rely only on the histomorphologic findings in this case. And the presence of the overlapping nuclei is not seen in the PLGA, which is a prominent feature, the main feature which Dr. Escalova mentioned in her book, the book of salivary gland. And the other thing is that the hyalinized stroma, which is the main feature of stroma in the cribriform adenocarcinoma of the tongue and minor salivary gland, is present and is not that much obvious within the polymorphous adenocarcinoma. The other things which we may consider the presence of different growth pattern, which are equally present in both PLGA and CAT, and there is no difference between their growth patterns. Both of them can show you more than 2 or 3 types of growth pattern, which is papillary cystic and papillary, micropapillary, and microcystic growth. These are the usual patterns, and you can find all of them. So if I want to conclude, I have to say there is no immunohistochemical differentiation between these tumor and these two main entity, and even in the literature, in the old literature, they consider these two entities as the same entity. And right now, by the different behavior which can be seen in the cribriform adenocarcinoma, they said you have to separate it from the PLGA. So this is important to know the histomorphologic findings here to can differ between these two entities. I hope I could answer it. And Dr. Monta, you're so welcome.
Yes. Okay, we have one more. Dr. Vivek says, respected ma'am, did the tongue, was it also having the same lesion as the lesion in the upper maxillary vestibule? This is in regards to case 3.
Let me check in upper maxillary vestibule. No, the tongue was free of any lesion, and the patient was only complaining of a year of having this lesion at the depth of vestibule in the maxillary area, and there was no lesion within the tongue. Actually, I have to emphasize that the name cribriform adenocarcinoma of tongue was first made for this entity, but as it can occur in other sites of oral cavity, and they conclude that to change the name as it is CAT MSG. And finally, we can say it is the cribriform adenocarcinoma of minor salivary gland if it occurs in minor ones, or in tongue if it is a case of tongue. But our patient didn't complain of any tongue lesion. It was a solitary lesion within the depth of maxillary vestibule only.
Thank you. We have one more here. Dr. Prabhu says, can we consider the last case as polymorphous adenocarcinoma according to the 2017 WHO classification?
Actually, according to the latest review literatures and papers, I mean the review articles published in 2021 and 22, it should be separated due to their behavioral difference. And if you say as polymorphous low-grade adenocarcinoma, you may lose the chance to evaluate the patient for the risk of metastasis. So we have the main point in this case that whenever you want to make the diagnosis of CAT, you should highlight this presence of metastasis for your surgeon. So if you say polymorphous low-grade adenocarcinoma, you are pointing to the tumor, which is low aggressive in behavior than a CAT. It is recommended to don't consider these two entities as the same one.
I think this is a continuation of that comment, probably where he says myoepithelial markers have limited expression in PLGA, but extensive expression in CAT. And I think he also has this here, which says low-grade term has been removed. Yes.
Yes, and now we don't have low-grade adenocarcinoma, polymorphous adenocarcinoma, but it is not only regarding to the grade of the tumor, it is regarding to the clinical course of the tumor. And it is there is more tend to metastasize in the CAT than the PLGA.
Okay. So we have Dr. Afrin Nadaf who says, thank you for wonderful presentations. And so does Dr. Prabhu and Dr. Puyan.
Thank you, everybody.
Right. So, are there any more questions? Yes, Dr. Nida. Okay. Dr. Sudhindra is saying thank you for the discussion.
Dr. Mandana?
No, there are no more questions. And that's it, I think. Yes, everyone loved the lecture. That's all. And the cases. So I'm going to request everybody who loved it so much, please remember to put a like.
Thank you so much.
Yes. You're most welcome.
Thank you so much.
We are having a lag.
For watching us. I think I lost my connection. Dr. Mandana, can you hear me?
Yes, I can hear you. But we are having a lag, so we tend to overlap. Yes. Anything you want to say, sure. Please go ahead.
I just want to finally thank you by the end of, I want to thank you again by the end of the lecture for your preparing this informative and I think somehow kind of let's say I can't find a word, but it was a great attempt for and it was a great I think pleasure for me to be here with you and with your colleagues to share my experience regarding the rare salivary gland malignancies. And I hope they help you to consider them by the time of diagnosis, although they are rare, but we have to consider them. Again, thank you, Dr. Mandana, for your kindly invitation and support. that's a great pleasure for me to be here for you.
Thank you. You're most
Thank you,
welcome.
Dr.
It was our
Mandana. Thank you so
pleasure.
much.
You're most welcome. And here is your little
Thank you.
certificate, which I will send to you afterwards. But here is the digital certificate.
Thank you so
Okay.
much. Thank you again.
You're most welcome. Okay, so a few bits of information, and let me just move this. Yes, everybody, thank you for watching. Now, in the coming week, coming Tuesday, we have Dr. Nagamani Narayana's lecture. It will be recorded, but it will premiere at 11 o'clock as usual. And she is also going to bring us some rare cases that were perplexing, but which she came across. Now, one more thing is I have some family medical situation that needs my attention. So you will find that you may not get all the reminders and all the details as you normally do from me and from, because as you know, I work with a very small, almost minuscule team. So, and we have our hands full also with preparing for the upcoming anniversary celebrations. The regular lectures will go on as usual. Nothing will stop, but you may have to find out about them on your own. Don't just wait for our information. Please go to the website and check out. Also, please share the information with each other. That will be very kind. I am sorry, but some things need attention first, and this is one of those situations. And but the programs will be on time and as usual. So I hope I will see you all turning up at 11 o'clock on Tuesday. We will have a premiere. This Dr. Nagamani's lecture will be a pre-recorded, and everything will go on as usual. So I just hope to see you all. We also have the upcoming anniversary celebrations. Again, please go to the website. You will find the details. There is a 3-hour program, an oral cancer update. Two field experts are going to be talking. One is on omics and systems biology tools for precision oral cancer diagnostics, especially addressing resource limited countries. And then is going to be HPV and head and neck cancer updates in diagnosis and testing. So these are two wonderful lectures, which I hope you will not miss. And then we also have a combination quiz treasure hunt sort of a thing together, which is being brought to you by the Goa Dental College team by Dr. Anita Spadigam and her team. That should be very interesting, and we will have a very interesting prize for that too. Otherwise, our partner for organizing this is the Vaidehi Dental College. Dr. Salvi is here because Salvi also is attending today. So anyway, the teams will be working. Everything will be going on as usual. You just need to register for this event because without the registration, although you can definitely watch it on YouTube, but you will not be able to get the certificate. And with that, that's all for this week. Have a safe week, and we shall see you all soon. Yes. Thank you, Dr. Nadav.
Inshallah.
Have a wonderful week.
You are so welcome. Have
Yes.
a wonderful day. Thank you so much.
Thank you. Thank you, everyone. Have a great time.